suggested. So, Eric, do you mind expounding a little bit on some of the measurement tools and just help us understand from a 30,000 foot view?
Yeah, so I think the easiest place to start, because this was Chad's invention, I thought it was ingenious at the time, and it was, okay, if you don't want to invest the time into understanding the nuances of sensitivity, specificity, likelihood ratios, diagnostic accuracy, and all of those things, what we're going to do is weigh all of those things for you, and here's the utility score. So I just thought that was fantastic, because that's mostly what people were looking for. And the rest of the statistics sort of just contribute to each other, right? There's different ways to configure a test when it's positive in somebody who has a pathology, or falsely positive in somebody who has the pathology, or negative in someone who doesn't have the pathology. So, there's really kind of two outcomes you want from a test to be a perfect test, and that is every time somebody has, I'll use an ACL tear because that's easy. Every time somebody has an ACL tear, you want the test to show up as positive. And if they don't have an ACL tear, you want the test to be negative. Well, so that's perfect accuracy, right? The problem is that as we did our research, we didn't find any tests like that anywhere ever, because they have faults. Those that were positive in an ACL tear, turned out they were positive a lot, and sometimes falsely positive a lot. So then, then their metrics, those sensitivity, specificity things start to suffer. So again, not to get too into the weeds, but I really kind of use likelihood ratios at this point, because likelihood ratios combine sensitivity and specificity. And, I just kind of remember sort of like a likelihood ratio of 1 is a coin flip. So in other words, the test that you're doing, you would be just as accurate if you flipped a coin and said, well, heads with this test means that the ACL is torn, and tails, it's not torn. And so I think 1 is a good anchor for me. And then as you get closer to 0 with likelihood ratios, you start to get down to like 0.1 or something like that. You're starting to rule out the ACL tear. And as you get above sort of 10 on a likelihood ratio, you're starting to strongly rule in. And again, accuracy is a combination of those two things, but I really like likelihood ratios. Sensitivity and specificity are hard, because as one goes up, the other one typically goes down. So the likelihood ratio evens those things out, if you will, and gives us a better idea of what the good tests are. And again, 1's kind of the anchor point. That's a useless test, really. Closer to 0 is a good at ruling out, and 10 or greater is great at ruling in the pathology.
The textbook really does a nice job of outlining how to use the text and how to understand those numbers. And Eric did write that chapter. It is very clean. I think every clinician has to go back and refresh their memory on these particular measures. I'm with Eric. I think likelihood ratios are the way to go, because it uses the full population and not just half the population, those with sensitivity measures, the other half with specificity. We also talk about a nomogram, which is a clinical decision-making support tool. It gives you a probability of having the condition with that test being positive or that test being negative. And it gives, I think, really wonderful perspective to the clinician of that single test and what value it has in making a diagnosis.
Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.